That I now invite Dr. Femina and Hashim for her talk on the puzzle of retinal vasculitis. She is a consultant at Chaitanya Eye Hospital, Trivandrum, Kerala, and her special interest is in the field of uvea and ocular inflammation. Over to you, Dr. Femina.
A very warm good morning to one and all. Today I will be discussing a young patient, 46-year-old lady without any systemic comorbidities, presented with our OP in complaints of floaters in the left eye for around 3 weeks duration. There was no specific systemic history or any uveitic history. Her best corrected visual acuity was 6/6 both eyes, and anterior segment there was no evidence of inflammation, except in the anterior vitreous phase there was few pigmented cells. So once we dilated, this was the fundus examination. You can see in the right eye there was neovascularization of the disc, and in the left eye there was no NVD, but whereas neovascularization of elsewhere was present with pre-retinal hemorrhages and settled hemorrhages. In both eye was showing peripheral sheathing or occlusive vasculitis. So under this diagnosis, we just did an uveitis and the vasculitis workup, but all investigations came negative, including the TB, sarcoidosis, and all other vasculitis. So we did an angiogram for this patient, and this is the angiogram picture, and you can clearly see how extensive is the gross peripheral ischemia. And there was in the right eye there was profuse disc leakage and mild perifoveal leakage, as well as the NVE was leaking with vasculitis and the peripheral shunting of the vessels. And the most importantly, there was gross peripheral ischemia. And this was the left eye picture. It was also showing the extensive peripheral ischemia or the capillary non-perfusion areas. So considering this extensive capillary non-perfusion, we have to do a diagnosis, but all other investigations came as negative. So we just revisited the case once again. So this was what we have found once you revisit the case. And in the right eye, the both eyes, you can see some beaded appearance of the vessels, which is not typical in usual cases. So, but we are not convinced with this beaded appearance of the vessels because these were not leaking in the angiogram. So this was the most turning point in our case, that is the beaded or the tide node appearance of the vessels. So coming to the summary, we have a case of bilateral occlusive vasculitis. It's a female patient in a young age, mainly having a beaded appearance of the vessels. And in the angiogram, you have some neuroretinitis-like features like disc leakage and macular leakage without any systemic workup positivity. So we just differentially diagnosed it as a case of idiopathic retinal vasculitis, aneurysms, and neuroretinitis because none other diagnosis was fit into our protocols. So we just diagnosed it as a IRVAN, and we just started with the oral steroids for this patient because in IRVAN most of the time the inflammation is the integral part. So we just started in an oral steroid along with considering the extensive capillary non-perfusion areas. We have just started with the peripheral PRP 3 sittings for both eyes. So this was the follow-up visit of the patient. Once the vision was absolutely normal, 6/6 in the initial visit also. So once we following the patient, there was the NV was regressing, NVD was regressing, and the vision was stable without the systemic improvement also. So idiopathic retinal vasculitis, aneurysms, and neuroretinitis is a rare clinical entity of unknown etiology, typically affects young, healthy individuals and has a female preponderance without any systemic association. And these are the most common stages. The stage 1, there will be macroaneurysms, exudation, neuroretinitis, retinal vasculitis. And in the second stage, there will be capillary non-perfusion, mainly in the angiographic evidence. And the third stage, there is posterior segment neovascularization of the disc or elsewhere and or vitreous hemorrhage. And the fourth stage, you will have an anterior segment neovascularization or rubeosis iridis. And fifth stage is neovascular glaucoma. So it's important to rule out other causes of vasculitis like a TB and other type of SLE, all these cases. And PRP to the extensive CNP and the neovascularization. And early laser has a better visual prognosis. And laser to the macroaneurysms may result in occlusion. Intravitreal anti-VEGF can be indicated for the macular edema, vitreous hemorrhage, or neovascularization. So my question to ma'am is, In these type of cases, usually we encounter in OP where we don't have a definite diagnosis. Most of the investigations will be negative. But considering the high amount of peripheral non-perfusion areas, do we need an extensive treatment or any immunosuppressive therapy for these type of patients?
Okay. So the thing is, the Irwan's prognosis, can vary from person to person. So if you look in the literature, there's cases of spontaneous regression of the aneurysms as well. So whether they need immunosuppressive therapy depends on whether they have active inflammation. And I would kind of use the FFA to guide it. If there is active inflammation, I would start treating them with oral steroids. And some of them might just need oral steroids. If that it's not working, you add a antimetabolite, conventional antimetabolite. But we have a couple of patients who have actually needed biologicals, injection adalimumab. So with really good results, So it depends on whether there is an active inflammation which is not controlled. So not all cases need conventional immunosuppressive therapy. And if there's no active inflammation, you don't need to treat it with immunosuppression.
Ma'am, in these type of cases, there won't be any active inflammation except all the peripheral occlusive vasculitis. Definitely, we should start the peripheral PRP. But is there any role of steroids in the initial visit for these type of patients? This patient we just randomly diagnosed as an IRWAN, but in most of the cases we couldn't find a diagnosis. But most of the investigations will be negative. So we will.
Yeah, so vasculitis is an integral part of it's a major diagnostic criteria. By that you mean you actually see vasculitis, you see vascular leakage. Your case may not have had it, but a lot of the IRWAN patients will have vasculitis. And that's one of the features which distinguishes IRWAN from other causes of aneurysms. Okay, there are other conditions, which can cause retinal aneurysm, but the vasculitis, is peculiar to IRWAN. So your case may not have had an active vasculitis, but most of them do. And there's a major criteria and a minor criteria. Yeah. What was the other question?
No, ma'am, not about this IRWAN. If there is a peripheral occlusive vasculitis, we couldn't find any diagnosis. In that cases, do we really need a steroid or PRP will be suffice?
Sometimes, if you think it's an inflammatory occlusive vasculitis, and you're going to laser very extensive areas, I like to give short steroid cover so that there's no flare up. Okay. That you're not actually treating an active inflammation. You're trying to prevent it. Something like giving a preoperative steroid cover before cataract surgery. Yeah,
Thank you.
do that.
Thank